Okay, so we should be live streaming this on Facebook, and I would like to welcome everyone. So we've got people who are in the webinar. We have people who are tuned in on Facebook, and we are recording this session as well. So for all who are watching, good morning, good afternoon, good evening. I am Dr. Akwi Asimbang, co-founder of the Pan-African Organization for Health Education and Research. I'd like to take this opportunity to welcome all of you today. And I would also like to take this opportunity to welcome our panelist and key speaker, Dr. Naeem Dalal. He has been extremely busy. He's always busy. He's out there, impacting, making a positive impact on the world. He's giving a lot of talks. And so we are absolutely grateful that in the middle of his busy schedule, that he's taken this time to spend with us today. Our focus is on mental health and HIV and chronic diseases. So, that's a really important topic. We have a lot of questions, and we're going to try and get to all those questions that you submitted. For those who are in the webinar, please feel free to type questions in the chat, especially if we don't get to them. For those who are watching this being live streamed, please feel free to just put your comment on the page. And on that note, our moderator for today is Miriam Wape, who is one of our Poher scholars and also a medical student at CBU Some. And so I will hand things over to Miriam, who will moderate the session, ask the questions. Every now and then I may pop in if we have any technical issues. But Miriam, over to you. And in the background, we do have Anya Avis Nobuth, who's our lead Poher scholar, helping as well. So this conversation is over to you, Dr. Dalal and Miriam. Welcome to everyone.
Thank you so much, Dr. Akwi. Welcome to everyone who's joining us in. We're glad to have you here. So I'll be having a conversation with Dr. Naeem Dalal on HIV and mental illness. So do feel free to post your questions. And I'd just like to invite Dr. Naeem Dalal to introduce himself, tell us about psychiatry, why he chose to take that route, and a bit of details about his career. Over to you, Dr. Dalal.
Hey, Miriam. And first off, really like your outfit. Really looking brilliant. Thank you so much for inviting me. Dr. Akwi, it's been a pleasure following Poher's journey so far, and I'm an ally and just a super productive person. As you've said, I don't like to call myself busy. I say productive, which is a good thing. So I'm very excited that Poher invited me, and more so for chronic conditions and talk about mental health. So to everyone, my name is Dr. Naeem Dalal. I'm also known as Dr. Ganizo, and I'll tell you later why as we communicate. But I am a psychiatrist, and I work in the field of mental health and well-being. I started out as an activist, stroke advocate in mental health, and then later on, through my medical journey, I realized that, okay, this is something that I can actually do because one key thing, I figured out that there's a huge gap in the mental health field. And one of the things that we always listen and hear, Miriam, and I'm sure you will understand this, is that why did you choose medicine? Or why do you want to be a doctor? Why do you want to be in a space where you are servicing people? And we always say we want to touch life, we want to help people. And this is one space where I saw there was a huge demand and there was a huge gap. And I personally have had people that I've looked after and that are in my friend circle, in my network, that have needed mental health services, and I myself didn't know where to go for. And so I decided to join mental health. Fun fact, I did not want to be a psychiatrist, but I am enjoying and loving every part of it. And as we go on with our communication and discussion today, you will know why. But I'm currently working with the Ministry of Health, strengthening mental health systems in the country here in Zambia, and also working with many Zambians, trying to support them as they come to their clinics and services looking for mental health services. So happy to be here.
Thank you so much, Dr. Dalal. Thank you for squeezing us in your productive day. Okay, so to start off, I would just briefly like you to explain what is the meaning of mental health. We hear people talking about mental health. Is having poor mental health the same as having a mental illness? Where do we draw the line?
Okay, so let's rewind a bit and start from the very beginning. Health. How do we define health? If you understand the definition of health, you are going to understand the definition of mental health. So health is a complete state of physical, mental, and social well-being, right? So there are three things in health. Health is a complete state of physical, mental, and social well-being, and not just the absence of, of disease or not just being ill. So now the point that you raised to say, what is mental health? What is poor mental health? And what is mental illness? Um, Mental health is basically, in a nutshell, I would literally just say how you feel and how you behave. And that is how we often define mental health. It has to do with your five senses, what you see in environment, what you feel in your environment, how you perceive things around you, and how you feel about these things. And also how your behavior is towards the things that you're feeling. Um, and the organ that is responsible for this in our body is the brain. And the brain is the master organ that controls all the five senses in our body. Now, when we talk about mental illness, it's basically saying that you are unable to be productive or you are unable to be functional in your day-to-day life. What do I mean by that? Functionality is basically something that comes naturally to you that you have learned throughout, your life. Even as a child, you grow up, you know that, okay, that this is bedtime, this is my time to go and sleep and rest. When I wake up, this is my routine. I brush my teeth or I wash my face. I grab something like a cup of tea to, nourish myself. This is your day-to-day routine, and this is you being functional and productive in your day-to-day life. When this becomes a challenge, when you're unable to be functional or there is some severity to or disruption towards this functionality, that is when we say, okay, there is a likelihood that you have, an illness. In terms of poor mental health, I don't appreciate using the word poor because it brings in, and we are going to discuss this later on, I'm sure, about stigma, but I do talk about it from a lens of unhealthy mental health. And every one of us has mental health, and this is something that everyone needs to understand. Miriam, I can't stress this enough. All of us have mental health. The difference is, are we productive enough? Are we functional enough to be able to understand how our mental health is? If we are not 100% productive, then there is a risk of us having unhealthy mental health. And should they be further risks, then there is a likelihood that we may have a mental health illness. Yes.
Okay, thank you so much for clarifying. From today onwards, we won't be using the word poor mental health. We'll be denoting it as unhealthy mental health. So you talked about unhealthy mental health. So what are some of these things that can tip someone into having unhealthy mental health? And also, what are just some of the conditions that are under unhealthy mental health or mental illness? Because usually from a society point of view, when someone says they're having unhealthy mental health, people always think of depression. Is that the only thing that's involved, or there are other factors?
So, undergrad, when I was going through medical school and the experience that I had in psychiatry, we were just given basic mental health conditions to understand, one of them being major depressive disorder and clinical depression. As youth today, we are very quick to say, I'm feeling low, I'm feeling depressed, but not to take away from you, but that's not clinical depression. There is a huge difference. But depression is one of the leading conditions that is diagnosed in mental illness today and all over the world. I'll start by sharing with you again the concept of unhealthy mental health and what are the risky habits towards that and what really makes us, tip into having unhealthy mental health habits. One of the things that we need to understand is the best example I can give you is chifua, the recurrent flus that we have. Okay, when someone has a flu, right? a common cold. Someone has a common cold today, 2 months down the line, they have another cold, which resolves, the immunity fights back. They don't take any medication. They rest it out. Again, 3 months later, they have another flu. Are we going to label that person to say that person is physically unwell, physically ill for life? Are we going to label that person? That's highly unlikely, and no. Similarly, all of us have mental health, and there are times when we have highs and there are times we have lows. And these highs and lows are not just things that happen to us inherently within us, but they're also external factors. And what more better example than the pandemic? Living through the pandemic, there have been so many uncertainties. This can predispose us to stress. Now, stress is anything that makes you feel overwhelmed and makes you feel threatened. And if you're going to have recurrent daily stressors, then there is a high likelihood that you're going to end up with what we call an acute stress reaction. And if that is something that is really, really taking a toll on you, then there is a high likelihood that you may have certain mental health symptoms. Again, this does not mean that you have a mental illness. This does not mean that you are mentally ill. This just means you're experiencing an episode or a period during which you are mentally unhealthy. And what are the things that you can see? One, your mood, where you know who you are. All of us, yes, go through different seasons of emotions and feelings, but you know who you are. You may be a lively, bubbly person, or you may be a reserved person, or you may be a mix of them, depending on the environment where you're in. That's your mood, persistent way of feeling. If that changes and that is persistent for say 2 to 3 weeks, then you can say, okay, there is a change in my mental well-being. The second thing is your sleep. The organ that is responsible for mental health is the brain. And the brain needs to relax, the brain needs to rest, the brain needs to take away its toxins. And the way it does this is through sleep. So if there's a disruption in your sleep-wake pattern, and this again goes from few days to a few weeks, when I say few weeks, 1 or 2 weeks, then again, that's going to have a disruption in your mental health and well-being. Then finally, the third key pillar for you to understand your mental health and well-being is your diet. Now, I'm not saying, Miriam, go and get this particular diet and just eat this food or that food. No. We have all grown up in our environment, the same food that we've been eating. Now, you need to understand whether you are moving away from your usual pattern of eating. Are you eating more or are you eating less? Whenever you're having periods of uncertainty, when you're overwhelmed, you'll find yourself craving savory foods. And in Zambia, I'm sorry, I'm just going to stereotype, and I'm sorry I'm going to say this because I experienced this not just in my network, but even in work, in my practice. Even before tasting the food, we are very quick to get the salt and just add it on top. These are ways that you can tell that, okay, these are unhealthy patterns that can predispose to this is unhealthy mental health, and this can predispose you to, in a long run, mental illness. Now, the second part of your question, Miriam, about conditions and whether it's only clinical depression. Just the way there's health, there's infectious diseases, there's autoimmune conditions, there's different organs that have different conditions. Mental health has so many different conditions under it, and in mental health we call them disorders because majority of the times we're talking about productivity and functionality of a person. So we can actually break them down starting from childhood, neurodevelopmental, whether these are inherited, and they have, neurodevelopmental conditions such as autism spectrum disorders, which again have so many different subtypes in that. Then we also have childhood conditions such as, learning disorders, okay, social support disorders, anxiety disorders. So all of these things are in childhood. Then we also talk about, psychotic spectrum disorders. Now, this is one thing that we always lean towards. And we always say mental health is that person who is behaving in an unusual way, but that's not true. Psychosis is basically where what you're seeing, what you're hearing, what you're feeling, or what you're perceiving may not be present. And this is very common, not just in pure mental health conditions, but also other conditions that can predispose to these symptoms. Then we also have mood or affective disorders. And this is where clinical depression or major depressive disorder actually comes in. But then on the other spectrum, we also have higher, high poles of mood, which we call mania, and this is where we call bipolar mood disorder. Then we have again in mood disorders, we also have, and this is very common amongst youth, dysthymia. Dysthymia is basically someone or anybody that is not really fitting the criteria of clinical depression, but they are just feeling meh. They're like not feeling happy, they're not feeling sad, they just feel in between the whole time. Every day they're going through their day-to-day life and they just don't feel 100%. That is dysthymia. Then we also have rapid cycling. Then we have the most common ones, which is the anxiety spectrum disorders, where we have generalized anxiety disorder, we have social anxiety disorder, we have different phobias, and then we have the obsessions and compulsive disorders. And then, of course, we have, certain conditions such as substance use disorders. This is where we have different substances, addictions come under substance use disorders. Then because the brain is also responsible for the sleep and the wake arousal and the sleep-wake cycle, then we also have sleep disorders, right? And then you can also go into the domain of, pleasure and sexual concerns, sex and reproductive concerns. And again, the brain is a master organ that is controlling everything. So we also have sex disorders. There are many, many different disorders that actually fall under mental health and psychiatry. And clinical depression is just like the tip of the iceberg.
Hey. Wow, thank you so much for that insight. I'm sure everyone has learned one or two things. We'll stop generalizing mental health just to depression. So as we've talked about these conditions, when can someone come to the hospital, or when should they seek medical help? And what are you going to do as a doctor? And also on that note, what things are there in place in order to make people easily access these services in terms of, yeah, sorry.
Okay, all right, Miriam. So when we talk about mental health and what is it that should people look out for, when should you say, okay, let's go to the doctor, let's go see a psychiatrist, or let's go see a mental health nurse or a clinical officer psychiatry, or just the mental health field? Ideally, if you feel uneasy, there shouldn't be really a reason why you should come to see me or any other person in the field. If you feel that you want to see a mental health specialist or professional, please, you're welcome to see us anytime. But there are actually, according to criteria, we actually look at, to summarize it, I will say three things. The first thing, if you are at risk to yourself, what do I mean by risk to self? Many people will just jump to the conclusion to say, Dr. Dalal is talking about suicide. I am talking about suicide, but I'm not really just referencing suicide. Risk to self means that the productivity that I mentioned earlier, the functionality, if you're unable to, go continue your day in the morning, some people may not even sleep, but if you're unable to wake up in the morning and brush your teeth, wash your face, grab something to eat, and go about your daily activities, be it at home, be it at work, then that is a risk to self, because you're not able to function, you're not able to focus on your well-being, you're not able to look after yourself. So that is what we call risk to self. If you have days where, for instance, then there's a difference. If you're grieving, you've lost a loved one, or you've just received bad news, then you can take some time to process it. When I say sometimes, I'm talking about 10 days to 3 weeks. That's fine, that's normal. You can have that period. But when it goes to a month or more and you're continuously being a risk to yourself, where you're not able to look after yourself, you're not being able to be functional, then hey, please don't delay, please see a mental health professional, because they will be able to guide and support you. This other part of risk to self is self-harm and suicidal thoughts, suicidal intent, and suicidal acts. Okay, if you are going to do that, and many times people think that suicide is just the end to a means. That's not true. There are many reasons why people have thoughts of not wanting to live or self-harm. Other people use self-harm or cutting as a means to feel something. Other people use self-harm or cutting as a means to express themselves. Other people use that as a means to say, I am not fine and this is the only way I can feel pain. So there are many, many reasons. But if there is that as well, then hey, you have to come and see a professional, a mental health professional. So that's one, risk to self. The second one is risk to others. Risk to others is where, when you're feeling overwhelmed mentally in any way, your behavior, your mood, your sleep, or your diet is disturbed in any way, there is a high chance that you may, partake in risky habits. And risky habits include things like, reckless spending. Sometimes you may be so sad or you may be so excited or aroused that, you may just go and spend all your money. The little money that you have, you may go and spend it. Or you may partake in risky habits such as drinking excessively or doing substances or drugs or even sexual practices. All of these things are, risks to others because you're not just going to affect your own life, but also the people that care for you and that you care for will directly be affected. Or because, you're in that position where you're thinking overwhelmed, um, you may actually do something to someone else, and that may be a risk to others. So if that were to happen, then hey, come and see a mental health professional. I will also use this as a means of saying you start one project, you don't finish it, you start another project. Okay, that too is, overwhelming yourself. And then the third thing is where someone else, because you're so overwhelmed yourself, someone else is taking advantage of you. All right. So in these cases, you need to reach out for professional help and to a mental health professional. And then your follow-up question to say, what happens when someone actually comes and sees me? Just like any other practice where you go to, there is what we call the first time you're going to see me, you're going to be screened. In that screening, in that assessment, we are going to create a therapeutic alliance where I'm going to find out how you are, what is it that brought you to me? Is it someone else that brought you to me? And if that's the case, what would you like to discuss? What are your concerns? What are your complaints? And then I will go on to take what we call a history. In the history is where I am literally asking you questions that are curated that will help me get the most positive information to help you best. So that is what's going to happen. In that history, I'm going to find out if there is any family history, if there is any other concerns that I need to know. From there, I will actually examine you. So there is a mental state examination, there is a neurological examination, and also if there is a physical concern that you have, for instance, HIV, so I will also examine all the other parts of your body so that we know if there is a concern there. And then from there, we will have certain investigations that will be done. And then that's how I will be able to come up with a diagnosis. So usually the first time you come and see a mental health professional, the interaction will be no less than 45 minutes to more so that we can get the most and we can actually help you with an assessment and a diagnosis.
Okay, thank you so much. So I just saw a question from the chat from Wizamo. She's asking, is grieving for more than 3 weeks unhealthy, and should someone seek professional help in that case?
So when we say grieving, we all grieve in very different ways. Grief is a feeling or an emotion that comes about when you have either lost a loved one, which is often the case where someone close to you is no longer with you, and you have to cope with that loss. Or it could also be losing something that you've worked towards for so long. Grief, for instance, in a dollar sense, would be something like failing a test or failing an exams, which you work so hard towards. Grief in a relationship would be, a broken relationship. That in itself is grief. Grief in a workspace would be losing a job or losing a particular project. So grief can come in many ways. Now, we all grieve in different ways. And our usual psychological behavior is such that it takes us at least a few weeks to a few months to actually process the whole sudden change in your reality because of that grief. But even as you're grieving, you can, from health perspective, there's a 10-day to say 14 to 21-day period in which you will be allowed to, maybe overlook certain key functional aspects of your life, such as not eating well, not sleeping well, or not, looking after yourself. But beyond that period, it will cause you more physical harm as well as mental and psychological turmoil. So in that case, we actually look in and we come in and say, it is normal that you're grieving, but there are healthy ways in grieving, and this is something that we guide you through. So to answer that question, Miriam, it is okay to grieve even for months. In fact, it's also okay to grieve for years, but you need to understand that there's also healthy grieving, and unhealthy grieving patterns actually should not continue beyond 3 weeks at max. But we have seen people that even grieve more than 6 months, and we have to intervene because that can actually predispose to other psychological trauma. But yes, there is a limit to healthy and unhealthy grieving.
Okay, thank you so much. I hope that's clear, Muiza. So I would also like to find out, okay, there was a question in the chat. They talked about insomnia and how it's related to mental health. I think you've already talked about that. You told us how anything that is not the usual can be determined as unhealthy mental health, and how everything is connected to the brain as the main control center. So from that note, I want to talk about chronic illnesses, things like HIV. How does this affect someone's mental health? Can it predispose them to unhealthy mental health?
Um, when we talk about chronic conditions, and in this case, where we are living in before COVID-19, HIV has been a pandemic that we have been living through as a country in Zambia, in sub-Saharan Africa, and the low middle income countries in particular. For chronic conditions such as HIV, you have to look at certain things where how has HIV come about? What have been the perceptions? How have societies supported people that have been diagnosed with HIV? What was the knowledge around HIV? And all these factors come into play. When we talk about HIV in particular, because of the lack of awareness, understanding, and support from the community, from the caregivers, from the family, it is very, very overwhelming to the person that has just been diagnosed with HIV, or a person living with HIV. Or in our case now, in our society today, we are seeing young people who were born with HIV, and now they're growing up and they're realizing that, oh, they were born with this condition. So with all that said, that clearly has an impact and does affect your mental health and psychological well-being. The best way I can explain this is how would you know, Miriam, to say, okay, Naeem, Dr. Dalal, you are at risk of a mental health condition. What you need to understand is that mental health, has, just like any health condition, has predisposing factors, things that can, put you at a higher risk of having them. And for us, we look at three things: the biology, the psychology, and the social part. So what do I mean by that? Biology basically means your genetics, what you have inherited from your mom's side and what you have inherited from your father's side, right? Your mother's side, your father's side, the lineage of DNA that has been passed on from generation to generation. A lot of conditions such as bipolar mood disorder, schizophrenia, which is a psychotic spectrum disorder, as well as substance use disorders such as alcoholism and alcohol use disorders, actually are genetically inherited. So that's the biology. Even before you're born, unfortunately, you are going to inherit certain genes that may predispose you to certain things. Then we have the psychology. With the psychology, it's the learned behaviors that you are surrounded by. This is what forms your thought processes. We call them cognitive schemata, and also metacognition, thinking about thinking. Sometimes a thought comes to your mind, you start thinking about something else. All of this is learned behaviors throughout your life. Okay, and this is where the concept of HIV comes in. Because if I have grown up with HIV, because I grew up after HIV was discovered, everywhere I'd see, I remember vividly growing up seeing billboards that would say, protect yourself, HIV kills. And I was just barely 10 or 11 and I'm reading these billboards. I can just imagine getting diagnosed with HIV then. I'd just be like, oh my goodness. That billboard said HIV kills. This means I have HIV, I'm going to die, you see? So that's the psychology, the thought processes. And then the third element is social factors. Social factors talk about your community and your society. Whether you are supported, whether your community and your society is equipped enough to hold you and support you through certain things in your life. This also includes your socioeconomic status. It also includes your education status, and all of this comes in. So all of these things actually predispose you to all those conditions I mentioned about mental health. Now for HIV, again, looking at our society and community, majority of our people are actually living in low socioeconomic statuses. And because of that, they don't have the perfect support structure. Even starting out in the early 1990s and 2000s, I wasn't there because I was still young. But looking at our health system, the support structure that is there and was there for HIV was not 100%. And because of that, that in itself is very overwhelming. And again, that can predispose to certain psychosocial turmoil and mental health conditions. So to answer your question, chronic conditions such as HIV are actually a risk factor to mental ill health. And unfortunately, HIV being a virus, it itself goes and attacks the brain. And it leads to what we call central nervous opportunistic infections. And when that happens, sometimes the person may present with, symptoms of psychiatry and mental health. Um, Again, HIV itself attacks the brain directly and leads to a lot of concerns in terms of symptoms such as poor memory. It also can lead to, confusion. It can also lead to psychotic symptoms. It can also lead to mania. So this is very common. And so to answer your question, yes, chronic conditions and in particular HIV does predispose to mental health concerns and illnesses in particular.
Thank you so much for shedding light on that. We can't run away from HIV, seeing that Southern Africa is mostly affected and a lot of people are affected by it. So looking at our country, Zambia, which has a high burden of HIV, is there a way that HIV services have been integrated with mental health services, or are these two still viewed as two separate entities?
Okay, speaking of Zambia, and also someone who's been privileged to be in sub-Saharan region and communicating and supporting in these fields in global mental health, unfortunately, that's been something that has been neglected. And before I come to that, I don't want to start with the sad part. I want to start with the happy part. Just more recently, it was announced that, if now that we are aware that mental health affects HIV and HIV affects mental health, it's like you can't look at them differently. All HIV systems are going to start looking at ways how to incorporate mental health services and integrate these services in the outputs. So that's very good news because this has been a policy that has just been come out. So I'm very happy about it. I'm even clapping. But as it stands right now, Miriam, to be honest, let's talk about our country here in Zambia, and even in sub-Saharan Africa, we don't have mental health systems in place. And those few spaces where we do have mental health services being provided, they are being provided separate to the actual health services. So it's like mental health and psychiatry is a super specialty, yes, but it is also just separated completely as a separate wing of service. And because of that, HIV mental health services are not integrated. I was shocked when I was doing my first year of my residency at the Tertiary Mental Health Hospital, where I was seeing so many people coming in, and unfortunately, there were no integrated structures. So these are a few of them were living with HIV, and they were not getting the full holistic support and structure. And so to answer your question, we don't have systems currently in place that are fully integrating mental health services as well as the HIV services. However, on the positive note, we have come such a long way that now we are thinking in that direction and going, I assure you, with young people coming up and systems evolving in the next 5 to 10 years, we are going to see a service which is together in primary healthcare, where people living with HIV get mental health services right at that level.
Okay, thank you so much. I also do hope to see a world in which more countries are integrating such services. So we talked about psychosocial factors and how some factors at community level predispose people living with chronic illnesses to unhealthy mental health. So I'd just like you to briefly explain what is stigma and what's the difference between stigmatization and discrimination? Is it the same thing when we say this? Are we talking about one and the same thing?
I'll take this opportunity to just give a shout out to God's General. He's an artist, and they recently, a couple of Zambian artists did an album called Ukani Manje, which is doing a bit of HIV awareness, understanding through music. And God's General's song, We Keep Fighting, actually talks about the two: no stigmatization, no discrimination. And these are two different things. In psychology and behavioral psychology, when we talk about stigma, we're actually talking about a label that we put on someone based on whether what they believe in, maybe how they appear, you know, depending on who they are. We just put a label on them. And that label is a negative label. So when someone sees you in a negative way, that's basically stigma. And it could be in any domain. It doesn't necessarily have to be how you look or what you do or what you see. It's just a label on you. It's like, just think of an X on you all the time, and whenever that X is seen, that's a negative X. So people just see you in that way. Then when we talk about discrimination, discrimination is when this is behavior towards you by someone else in a negative way. And when someone treats you in a negative way because of what you believe in or what you appear as or who you are, that is discrimination. And because these two things are oftentimes synonymous, they are looked at in the same way. It's not the same way, because it is very easy to see that you're being discriminated, because that's a direct behavior or action towards you, and you will see someone doing that towards you, treating you in a certain way, in a negative way, and you will experience that. So you can clearly vocalize that to say, I have been discriminated by so-and-so because of so-and-so. But with stigmatization, it's very difficult to tell, because sometimes it's subconscious or conscious, where people are just thinking it and they're just seeing that happen. And so it's very different. Stigma, discrimination are two different things. And again, just to summarize, stigma is when someone sees you in a negative way because of who you are, but discrimination is when someone treats you in a negative way because of who you are.
Okay, thank you so much. And thank you so much to everyone who's following our discussion. All your questions will be attended to in due time. So I'd like to find out, what are some of the approaches that we can use at community level to end stigma? Or do you really think stigma can come to an end?
That's, to be honest, that's a hard one. I say this because, as I said, I started my journey as an advocate turned activist. An advocate is someone who champions a cause. An activist is someone who champions a cause to bring about social change. And I started this when I was 16, and I'm almost concluding my 20s now. So I started out very early, and I'm just seeing changes, happening over a span of a decade. And I say that it's a hard one because it's a game of patience when it comes to stigma. And with stigma, as I said, it's about how someone sees you, and you can't necessarily tell whether someone is stigmatizing against you, because it's very difficult to prove. So again, it's very hard to break those beliefs and understandings in someone else. But I do believe there is hope. And to come back to your first half of your question, where you're asking to say, what can we do to create this understanding towards mental health, then the answer to that is mental health literacy. Mental health literacy basically talks about awareness as understanding and acceptance. Because many times we look at mental health and say, okay, we need to create more mental health awareness. So here's me telling you, oh yes, Miriam, guess what? Mental health is real. There's this condition, this is why this person feels like this. Suicide, it's serious. Someone just doesn't decide to just end their life. This. You're creating awareness, which is very important. But then I also need to make sure that as I'm talking to you, Miriam, I'm creating that awareness. I'm also planting a seed of acceptance in you to say what Dr. Dalal is telling me. Yes, I am aware about it, and I accept it, and I'm going to start implementing it. So this is where mental health literacy comes in. We need structures in place where we are not just promoting awareness for mental health and well-being and illness, but we are also promoting acceptance for mental health, well-being, and illness. Because, again, the challenge is when people reach out for mental health services, you may bring someone, maybe you bring your friend, your family member for services. I will support them, but they will go back out in that community, which will, not support them fully. They will not integrate them because of the current understanding about mental health. So because of that, again, it creates an issue. This is why I'm saying with stigma, it's a game of patience. We will get there, but there's a lot of work to be done. But on the other hand, how we can create more, acceptance, understanding, awareness is by promoting mental health literacy. And again, Miriam, I'm going to stress this. We are very quick to, take a copy paste approach. I say this because conditions for mental health and psychiatry are local and tailored to culture and beliefs. And we need to understand that we cannot just take an approach that is working in another system, another region, another practice, such as the Western world or the European cities or countries. We need to tailor our own mental health services. This is where we talk about transcultural psychiatry. And this is why when we talk about mental health literacy, we need to tailor it to our people. What do I mean by that? Our people. Let's talk about our reality here. I am a born and bred second generation Zambian. All right. So my friends are all Zambian. I relate as a Zambian person. Before, at the end of the day, in the rural setups, when people end their day, they sit around a fire or they sit around in their communities and they're talking about their day. That in itself is a form of therapy, which was embedded in our culture. But today, that is no longer the case. We are seeing this rural to urban shift, and even in rural spaces, in villages, there is more Western influence or the urban influence that is coming in, and that is being taken away. Okay, let's talk about psychiatry and child and maternal psychiatry. We are seeing more and more young women that are delivering today going through a very challenging postnatal period, including the male person who's supporting them. Because, there's that proverb in the African setup where they say, it takes a village to grow a child. And this is what we know as a culture in our country as well, in sub-Saharan Africa, in Africa in general. But that is no longer the case because, we are all growing up in these, siloed homes now, and that support structure is not there. So all of this, again, Miriam, to answer your question, mental health literacy is the answer, but it's not a copy-paste approach. It's actually a tailored mental health literacy to our people so that we communicate to them, we guide them, and we support them through the embedded culture so that they understand what mental health is.
Okay, thank you very much for that. I like that you brought about the fact that it has to be tailored. So looking at society, there are different groups of people that are affected by HIV and mental health in general. And we've seen that these people will be affected differently at every level. So I'd like to bring about maybe 3 or 4 groups. On one hand, we have women and young adolescent girls. They mostly take up the huge burden of HIV and AIDS. So how is it that, or how can we as a society better help these people to come about, access HIV services and also mental health services, seeing that they're mostly affected? Then on the other hand, we have young children, probably children who are born with HIV. So how can we make these children easily accept their condition, and also access for adolescents? How can they easily access sexual reproductive health services without being stereotyped? Then on the other hand, we have the adult males. Okay, we know in society mostly a man is supposed to be strong. Sometimes the man is the head of the house. They do things according to that. So how do we encourage more men to access mental health services and also HIV services? How do we make them open up about their status and also show that it's okay to go through these things to society without being seen as a weak male? Then the 4th group of people that I would like to bring about, obviously we have sex workers in our society, and we also now we have homosexuals. So how do we target these people? How do we make them more comfortable without the fear of them being stigmatized or being labeled by society? So how do we encourage these people to access these services without being labeled in a bad light?
Okay, so this has to do with our uh, psychology and our learned understanding and behaviors and thought processes. When we talk about all these four groups that you've mentioned, it has to do with, what society deems to be okay and what society deems not to be okay. Unfortunately, for starters, mental health, mental well-being, and mental illness is deemed not to be okay by society. So already there is that layer, and boundary of stigma already associated, and discrimination. With mental health, there is already discrimination happening within our societies for people living with mental health conditions. Same thing applies with HIV now. Now, HIV has come a long way in the past 2 decades. We are now seeing more people opening up about the HIV status, people living with HIV. Shout out to everyone living with HIV and sharing their journey, because you are the best people with lived experience to guide us who are not living with that. Another support structure that I would like to guide is understanding that people that are caring for people living with HIV as well, they themselves also go through the burden and stress of supporting people living with HIV due to the surrounding stigma and discrimination that comes with it. Now, so there's already these boundaries that are already present. Now, how do you support, for instance, the young girls? Because young girls are the majority of the population, adolescents as well as young girls, and they are at a higher risk of catching HIV. Because again, now another boundary and layer comes in, which is known as culture and belief structures, and to an extent also religion. Because society, for instance, in Zambia and sub-Saharan Africa and many other cultures around the world, um, request young women in general to be submissive. Okay, and because of that, they are at a higher risk of being vulnerable and being at that receiving end of certain ailments like HIV. um, then we talk about the second group that you're talking about, which is the adolescents, young people. How do they get access? Good news is, Miriam, young people today are more open about the concerns that they're facing. There is a shift, and I actually did a TED talk on this more recently, where I was sharing the different generational divides that we are currently experiencing between the adults of yesteryears versus the young ones, or the adolescents and young people growing up today. People growing up today are more open about sharing their challenges. And for them, that is actually a positive thing, because they're reaching out for support. But the challenge again is coming back when they're going back to their homes and requesting the adults to support them. Then the third group that you actually share are men. Again, this comes back to our culture, our beliefs, and the concept of masculinity. Even today, in a Zambian home, you will have a boy child and a girl child. Both the boy child and the girl child are being groomed to thrive as independents, but then you will still see that the girl child will still requested to do certain things that the boy child will not. And the boy child will ask to do certain things that the girl child will not. Again, that in itself is actually breeding this. Let's talk about the holiday season. You will see the girl child doing the chores at home, but the boy child will just play or will just be around the men. We are grooming these societies within ourselves, and mixed messaging is actually taking place amongst parenting as well today. So there is that. And then finally, you speak about the socially discriminated or excluded groups in our communities. And this has to not just do with culture and beliefs, but also religion. We talk about people that practice, same sex, or sex workers. These are marginalized. The answer to all of these groups, Miriam, is twofold. The the first one is creating spaces for these conversations to take place. Just what we're doing right now. We need to have these conversations at grassroots levels, where we're having an open conversation, where we're not going to someone and telling them that you are wrong, but rather going from a place of guidance and support. This has to happen across all these four groups, so that there is that conversation taking place. And secondly, for all these four groups, we need tailored services to be offered. What do I mean by that? For instance, when you come to my department, we have Mondays where we offer child and adolescent psychiatry services. Tuesdays where we offer adult psychiatry services. Wednesdays where we offer substance use psychiatry services. Thursdays where we offer therapy services, and Fridays where we offer psychiatry services to people with other underlying physical conditions. So this is what we call tailored approach, where you're actually grouping individuals that have similar themes, and they're actually being asked on a specifically day to come through so that they feel the support they need. Similarly, for all these 4 groups, if it means offering tailored support, they need to be offered that support, especially for the 4th group, which is discriminated and socially excluded. They may not feel welcome, and they are not that they may not feel they are not welcome. So having special days. At university teaching hospitals on Saturdays, the HIV Center of Excellence actually has a special clinic for special populations, so that they can get their own day where they can get their support and access to people like myself and other specialists so that they get the support. So to answer all these 4 groups, we need to have these conversations, not amongst educated people like you and I, but rather at grassroots level so that we create this awareness. And secondly, tailored structured support clinics for services that these 4 groups actually feel they are welcome and they can get the support.
Thank you so much. So if there's anyone out there battling with mental health, HIV, stigma, or anything, please feel free to walk into any healthcare service provider and you'll be attended to, and you acknowledge you're strong and we see you. So another thing I'd like to talk about is there's this concept of internalized stigma. We're talking about stigma in relation to coming from the outside society. What about internalized stigma? And what are some of the self-care tips that you can give to someone out there who's battling with things that they do not talk about in the open?
For this one, Miriam, I will just summarize the answer, but after this conversation, I'll share a link with you. I was privileged to do a talk at HIV conference where I spoke about a topic called I am not HIV/AIDS, I am not my diagnosis. And when you talk about internalized stigma, we're talking about self-stigma. This is something that people don't understand. When you grow up in a society or community where you're constantly being told, like I gave you the example, to say there were billboards, there are still billboards right now, where you are seeing, just outside, you're seeing HIV kills, know your status. The question, Miriam, is that billboard directed at a person living with HIV, or is that billboard directed at a person not living with HIV? Because a person who's living with HIV, when they read that billboard, they're going to feel like, wow, I have this disease. What does that say about me? I'm a living person who is living on borrowed time, because that's what the HIV messaging is saying, okay? Or there's also billboards outside there where they just literally say, know your status. And then there's a picture of, a couple there where, this man is cheating, literally cheating with 2 girls at one time. And that's a billboard right there outside. What is that saying about people living with HIV? Is that saying that people living with HIV are hiding their status? You see, so there's a lot of stigma that is promoted by the messaging that is out there. And the question is, in as much as these billboards may be promoting awareness for people not yet living with HIV, it's actually causing a lot of harm to people living with HIV. And also based on the things that we read on the internet or even talk about in our communities, it has a very strong impact. The saying that sticks and stones may break my bones, but words will not hurt me is false. It's total falsehood, because words do hurt. And this is what promotes stigma. Now imagine living with yourself and labeling yourself negative. Every day you're waking up, and this is a label. You constantly just keep looking at yourself. You've just labeled yourself. It's just an X marks you all the time. And you're just thinking of yourself negative. And you shy away from certain things that you have rights about. Okay, you have every right to live, to educate yourself, to get food, to shelter, to water. But because you have this condition, you tell yourself, no, I don't deserve this because I have HIV. This is what we call stigma, self-stigma in particular. And so people need to understand that if you have HIV, you are not HIV. You are not your diagnosis. HIV is but a part of you, but it is not who you are. You are still this amazing person. You still have these amazing skills. You still have these amazing talents. You still have a lot in you that you can still live with. And one other thing that promotes self-stigma is this definition of, hi, my name is Naeem, I am HIV positive. No, my name is Naeem, I am so and so, I am a son, I am an uncle, I am a nephew, I am a grandchild, I am a teacher, I am a lecturer, I work in the health field. And if I want to share, I will share I have HIV. HIV should not be the first thing that you say, my name is Naeem, I am HIV positive. No. So self-stigma is really, really strong. And a lot of people today are living with it, but that shouldn't be the case. And I'd be very happy to share the talk on I am not my diagnosis, I am not HIV, because it shares a lot of tips on how you need to understand that, grow out from that mindset to say, hey, HIV is me and me is HIV. No, there's a lot of you that is not HIV. HIV is just, an infection that has you, but because you are healthy and living, it's not even something you should be thinking about. Yeah.
Thank you so much. We're basically redefining the norms here. And I'm glad that you've come out so strongly that people shouldn't view themselves as their diagnosis. Yeah, so you talked about sharing a link. I'll gladly receive that and it can be shared with the audience. So are there any other places that you can recommend, probably internet sites or physical places where people can go to assess mental health services, probably physically or online, that you would recommend, except for the hospital, probably?
Okay, so as I guided earlier on to say, unfortunately, we are still working on our mental health systems in the country, and there are not that many. There are quite a few in the private sector, but again, most of them are centered heavily in Lusaka in Zambia. I will again share a list with you that has many numbers of private and a few government mental health systems where people can go for help. But I will, for those who are joining us in Zambia here, I will actually ask all of you to remember this number 116. It's a toll-free line. You will have probably seen this number. It's called Lifeline Zambia. And these are psychosocial counselors that have been trained in supporting people that are living with certain concerns. And I have had the privilege of supporting and training and also helping them with debriefing sessions. And I cannot recommend them enough. And the reason why I am recommending this number 116 right now is because over the past 3 years that I've asked people to call this number, 7 out of 10 people have said they are very grateful because they got the support that they wanted. There were 3 out of 10 that felt they wanted more support, and for those, I would actually request that you reach out to a professional mental health provider or a healthcare worker. But otherwise, 116 in Zambia is a good place to start. And again, in the follow-up in the link, we can also share the list that I speak of.
Okay, thank you so much. And yeah, so reach out if you're facing any challenges. Like Dr. Dalal has said, you can call 116. You can reach out to the healthcare provider. You can walk into the hospital and you'll be attended to. You're not alone. So thank you. I would just to take you back a little bit, there were some questions in the chat that were not addressed. So one of the questions was, when does anxiety become a problem? And the second question was, what are the risk factors that predispose someone to psychiatric disorders?
Okay, so when does anxiety become a problem? So all of us have an element of anxiety. Anxiety is, in a most simplest way I can say it, is the fear of unknown or the fear of uncertainty. For instance, you're afraid of, say, a particular insect, and you see that insect and you are warranted to feel overwhelmed and you avoid that place. That's anxiety. But for some people, even without that insect being there, just the thought that in that room there may be that insect, that person doesn't go in that room. That is what we call anxiety. And there's literal neurotransmitter imbalances that are happening in your brain that leads you to feel the way you feel. There are different types of anxieties, the most common ones being generalized anxiety disorder, where you feel uneasy about everything in your life, no specific thing. And then there's also social anxiety disorder, where you are uncomfortable in social spaces or in spaces where there are a lot of people that you don't know. Then we also have other anxieties that are no longer under the anxiety spectrum, but things such as obsessive compulsive disorders, where you have certain obsessions, behaviors, and you are made to, or thoughts, and then you have these behaviors that you carry out. What happens with anxiety is that you elicit what we call aversion. Aversion is where you avoid certain things. There are people that have certain phobias, such as, a phobia of a dog. And there may be a neighborhood house which has a dog. And because that person has to walk by that person's house, they will not walk by. They will use another route, which is maybe 40, 50 minutes longer, as opposed to using the 10-minute route, which is shorter, just to avoid that dog. So there are different types of anxieties and aversion leads to. Now, when does it become a problem? It becomes a problem when you're going above and beyond to avoid these things, and it's causing a toll in your day-to-day life, such that for instance, you are not being productive. You're not getting your education because you're anxious. You're not going to work because you're anxious. You're not eating well because you're anxious. You're not sleeping well because you're anxious. So all of these things, when they affect your daily functioning, then it's a problem. And if that's a problem, and when I say a problem, I don't mean like I'm labeling you. No, I'm telling you to say it is a problem that can get treated and then get supported through a mental health service provider like myself. So that's anxiety. Miriam, what was the second half of the question?
The second question was, what are the risk factors that predispose to psychiatric disorders?
Okay, so risk factors, as I guided earlier on, I used a very scientific term and medical term, which is the biopsychosocial model. Biopsychosocial basically means biology, psychology, and social. Biology is where genetics and inheritance. You may have inherited certain genes and DNA from your father's side or your mother's side. And this may predispose you to a mental health condition. Conditions such as bipolar mood disorder, clinical depression, anxiety spectrum disorders, psychotic spectrum disorders such as schizophrenia, substance use disorders such as alcohol use or addictions. All of these are actually inherited as well to an element. Now, it doesn't mean that if I have inherited this condition, I will end up having it. No. The second link is the psychology. The psychology is learned behaviors. For instance, if you've always been told that the car is bad, the car is bad, or you've learned that the car is bad, the car is bad, when you go in from a rural space to an urban setting and then you are being asked to use a car, you're not going to use a car. That doesn't mean you are wrong. It just means that's your learned behavior. So that is another part that can predispose you to certain mental health concerns, such as anxiety. And then the social part. The social part is your community, your education, your support structures, your culture, your beliefs, and your values. All of these can actually predispose to, mental health conditions. And there's no one size fits all. We all have different patterns that can predispose to mental health conditions. And this is why, before you go on to self-diagnose yourself, always have yourself assessed by a professional so that you actually know what is it that you're feeling.
Okay, thank you so much, Dr. Dalal. We're very grateful for having you on this session. We've had so much great information. We're so privileged. And like someone said in the chats, we should normalize having some of these talks. Mental health is something that we should really talk about, and we're grateful. So do you have any final words that you can say to people out there who are watching?
What I will say is, if you feel overwhelmed, if you feel different, or if you feel you need support, please don't hesitate. Reach out to a mental health care provider. One thing that I will say again, Miriam, is unfortunately, because we are living in a society where even our healthcare workers and our healthcare providers, my own colleagues, have actually lived through this reality. They themselves may not be as understanding as I am. but we are getting there. Don't lose hope. Slowly but surely we will get support. But if you are overwhelmed, please reach out for support, and we will be here waiting to help you with open arms.
Okay. Thank you so much. Indeed, if you do feel overwhelmed, please reach out. Thank you so much, Dr. Dalal. At this point, I'd like to switch over to Dr. Asambang just to usher us towards the end of the session. Dr. Asambang.
Thank you. That was very, very heavy. I think I personally will have to, listen to this over and over again. I liked how you were able to define terms. I liked how you were able to define stigma, to define discrimination. And, I liked how you started off in terms of saying, we all have mental health, but there's the highs and lows. And I really liked when you brought up that saying about sticks and bones, because that is so, we always say that sticks and bones, break my bones, but words won't hurt. But you're right, when you think about it, words do hurt. So I really, really enjoyed this conversation. I mean, this was really, really powerful. We do have a lot of questions. We've had a lot of comments. For those who are watching in the webinar, you'll see there's comments in the chat. And I'm just, I'm really, really thrilled and happy that you could, bring this up, because I think there's so many components, whether, that can impact the mental health, whether it's mental, physical abuse, emotional abuse, verbal abuse. All of those can impact our mental health. So I'm really short of words, because this was really, really powerful. And I'm hoping we can bring you back. I know I look at your schedules and I'm like, oh my God, he's here, he's there, he's here. But I think for some of us, this is like therapy. I'm like, yes, Dr. Dalal, preach on, Dr. Dalal. Yes, and now what do I do? And the questions are just coming, and Miriam handled them so well as well. So I thank you. On behalf of Poher, I am absolutely grateful for your time. This is an important topic, and hope we'll touch on this again. I'm really grateful. And on a personal note as well, I would say thank you so much for your time. And to everyone who's watching, we have to be, as always, respectful of time. We've been at this for over an hour. We'll have another session, hopefully, depending on how schedules work. And I'd want to wish everyone a fantastic day. So good morning, good afternoon, good evening to whoever is watching, wherever you are. I know I'm going to listen to this video recording over and over again. These are some really powerful words. Oh, but once again, Dr. Dalal, I mean, I know what Ganizo means. I speak Nyanja. So you mentioned I don't know if you, early on, you said before we say goodbye, could you touch on that, Dr. Ganizo? Just touch on that for the audience.
Yes, so one of the things that I've realized is certain mental health conditions don't have a name to it in our local languages, in our local culture. And also, one thing I realized, I've been privileged to also tutor, teach, and lecture a lot of medical students and allied healthcare students. Whenever I'm talking about brain health, it seems like it's just very overwhelming. So whenever I translate it into local languages that work well, it really makes a lot more impact and understanding, including in my clients, in my practice, and people that come from different walks of lives. When we translate these conditions in local languages, it just helps. And I've been doing a lot of grassroots outreaches, and from nowhere, there's this outreach where I keep going in Garden compound as well as in Chawama, and they just started calling me Dr. Ganizo, Dr. Ganizo Abuela. And then they're like, what do you mean by that? It was like, you beautifully explain the brain health, and you take us away from understanding culture and spirituality to now making us understand what brain health is. So, you speak so well about emotions and understanding them. So thank you so much. And that's how that concept has come through. So I've just happily taken that name up to say Dr. Ganizo, and it just makes people understand. When someone is having a emotional concern or mood disorder, I just tell them to say, Maganizo Zapaka, your thought processes are overwhelming you, and this is why you're feeling the way you're feeling. And then they're like, oh wow, there's an organ that's responsible for this. And yeah, it's not all cultural. So yeah, so that's where Dr. Ganizo, the street name, comes from, and I'm very proud of it because of the people that labeled me that, and I'm very happy with that label. Thank you for allowing me to share that.
Yeah, thank you, thank you. Yeah, so Dr. Dalal, his street name is Dr. Ganizo. So thoughts. As a gastroenterologist, I can start to think or imagine what type of street names I may have, but I digress. So once again, Naeem, I really appreciate you. I really can't express enough how grateful I am. This is such a sensitive topic, or at least we make it a sensitive topic in society. I think we should have more of these conversations. So, and Miriam, thank you for your time as well. So to all, good morning, good afternoon, good evening. Plug in tomorrow, we have our graduation ceremony. So if you're available, please join us. Our 10 fantastic scholars are going to present. They'll talk about themselves. They'll talk about, one or two or 10 or however many projects they've done over the year. And so if you have time, please join us tomorrow as we celebrate our fantabulous Poor Hair Scholars. To all, have a fantastic day. Good morning, good afternoon, good evening, and signing off. Thank you very much.